My name is Dr. Lori Conway. I spent 23 years as a vascular and general surgeon, and what I am about to share with you is not a scare tactic. It is not anti-medicine. It is the conversation I wish every patient over 60 was having with their doctor before they ever picked up a pen to sign anything. Because surgery at 60, 70, 80 is not automatically the same as surgery at 40. And the sooner we talk about that honestly, the better the outcomes get. Here is the foundation you need before we go anywhere. The human body after 60 is not broken. It is not a liability, but it does operate by different rules. Think of it this way. A river that has been flowing for 7 decades has carved channels that a younger river hasn't. Some of those channels run deep and strong. Others have narrowed. When you introduce the trauma of major surgery into that system, you are not just cutting and closing. You are sending a shockwave through every system in the body simultaneously. The cardiovascular system, the renal system, the pulmonary system, and critically, the neurological system. There is a condition called post-surgical cognitive decline that most patients have never heard of. In people over 70, the brain can emerge from general anesthesia in a fog that lasts not hours, but weeks, sometimes months. Memory slips, concentration fractures, personality subtly shifts. Families notice it before the patient does, and yet it is almost never listed on the consent form. That absence is one of the most significant problems in modern surgical care for older adults. None of this means surgery is wrong. Surgery is one of humanity's greatest medical achievements. I have stood in operating rooms and watched people get their lives back. What I am saying is that the decision for surgery should never be a conveyor belt. It should be a conversation. And that conversation should include these 5 categories of procedures, where the risks after 60 deserve far more weight than they typically receive. When the arteries feeding the heart become dangerously narrowed, the traditional surgical answer has been coronary bypass grafting. The chest is opened, the heart is stopped, and a machine takes over its function, while the surgeon reroutes blood flow. For a healthy 55-year-old, this can be a life-extending procedure. For a 76-year-old managing diabetes, diminished kidney function, and early cognitive changes, that same procedure can trigger a cascade of complications that overshadows any benefit it delivers. Research published across multiple cardiothoracic journals shows that in elderly patients classified as having low physiological reserve, what clinicians now formally call frailty, the rate of serious postoperative events following open cardiac surgery climbs past 35%. We are talking about strokes, acute kidney injury requiring dialysis, prolonged ventilator dependence, and severe neurological confusion lasting weeks. And mortality within the first month for the highest risk group reaches numbers that most patients are never shown before signing consent. Here is what has changed the landscape: transcatheter procedures. Instead of opening the chest, surgeons thread a catheter through a blood vessel and deliver treatment directly to the heart without ever stopping it. The recovery trajectory is dramatically different. The physiological toll is a fraction of open surgery. For many older adults with valve disease or certain blockages, this approach now exists as a real option. The problem is that it does not always get offered unless the patient asks. So ask. Specifically ask whether a catheter-based alternative is appropriate for your anatomy and health profile. That single question has redirected hundreds of treatment plans. Almost every person over 65 has some degree of spinal degeneration. It shows up on imaging. Discs narrow, vertebrae shift, bone spurs form. And because the imaging looks dramatic, the recommendation that follows sometimes sounds equally dramatic: fusion surgery, metal rods, screws, multiple vertebral levels locked into permanent rigidity. What the research shows, however, is more complicated than the images suggest. A landmark analysis of outcomes in patients over 65 who underwent complex spinal fusion found complication rates exceeding 40%. And the complications were not trivial: deep infections, hardware failure requiring revision surgery, blood clots, and a phenomenon called adjacent segment disease, where the vertebrae neighboring the fused section begin to degrade faster because they are absorbing mechanical forces the fused section no longer can. You fix one problem and accelerate another. More troubling still is what the long-term pain data actually shows. For many older adults with degenerative spine disease, the gap in pain relief between aggressive surgical fusion and a structured conservative program, physical therapy, targeted epidural injections, anti-inflammatory protocols, is far narrower than patients expect. In some studies, it is essentially zero at the 5-year mark, with the surgical group carrying all the procedural risk and the non-surgical group arriving at the same outcome through a safer path. If you have been told that fusion is your only remaining option for chronic back pain, I want to be direct with you. Get a second opinion. Then get a third if needed. Ask specifically about outcomes for patients in your age range and health profile. The spine is not a simple structure, and treating it aggressively in an aging body requires extraordinary justification. A cancer diagnosis triggers something primal. Remove it, destroy it, get it out of the body. That instinct is completely understandable, and in many cases, medically correct. But 2 decades in surgery taught me something that took time to fully accept. The goal of oncological treatment is not simply to eliminate the tumor. The goal is to deliver more quality time to the patient. Those two objectives do not always lead to the same decision. Some of the most technically demanding operations in surgery involve removing tumors in the abdomen, the pancreas, the liver, sections of the colon. These procedures can last the better part of a day. They require the body to mount a massive healing response afterward. In a 50-year-old with no other health issues, that healing response is formidable. In an 82-year-old with heart disease, reduced lung capacity, and compromised immune function, the body's ability to survive not the cancer, but the intervention itself becomes the central question. A study from the American College of Surgeons examined what they termed failure to rescue, situations where a complication occurred after major cancer surgery in an elderly patient, and the physiological reserves simply were not there to survive it. Nearly 1 in 5 elderly patients in the study fell into this category. They survived the surgery, the tumor was removed, and they still did not make it because their bodies could not absorb the surgical insult. What every older cancer patient deserves to hear is this question: what does the treatment landscape look like if surgery is taken off the table? Radiation has become extraordinarily precise. Targeted therapies that attack specific tumor markers have transformed outcomes in cancers that once had no good options. Watchful waiting with defined intervention triggers is appropriate in some slow-moving cancers. These conversations deserve equal time with the surgical conversation, not a footnote at the end. Hip and knee replacement surgery, when performed on the right patient at the right time, can be genuinely transformational. I have seen people who had stopped leaving their homes reclaim full active lives after successful joint replacement. I will not diminish that. But the phrase elective surgery carries within it something important: time. Unlike an emergency, an elective procedure can be scheduled, which means it can be prepared for. And in older adults with multiple health conditions, that preparation is not optional. It is the difference between a smooth recovery and a serious complication. The risks that escalate in older patients with conditions like heart disease, uncontrolled diabetes, obesity, or chronic kidney disease include blood clots that form in the legs and travel to the lungs, post-operative pneumonia from restricted movement during recovery, hospital-acquired infections, and cardiac events triggered by the physiological stress of surgery and anesthesia. These are not rare edge cases. They are documented, measurable risks that increase meaningfully when underlying conditions are not optimized before the procedure. There is now a growing movement in orthopedic surgery called rehabilitation, a structured program of cardiovascular conditioning, nutritional support, blood sugar management, and physical preparation that patients complete before their surgery date. Hospitals that have implemented formal rehabilitation programs for high-risk elderly patients have seen complication rates drop significantly. If your surgeon has not discussed this concept with you ahead of a planned joint replacement, bring it up yourself. Ask what you can do in the weeks before surgery to put your body in the strongest possible position. The answer to that question matters enormously. This one is different from every other entry on this list, and I need to explain why it belongs here. You cannot schedule an emergency. A bowel perforation, a ruptured abdominal vessel, acute appendicitis. These events arrive without warning, often in the middle of the night, and the decisions around them get made in hospital corridors by family members who are frightened, exhausted, and completely unprepared. Emergency abdominal surgery in patients over 75 carries some of the highest mortality figures in all of surgical care. In the most severe presentations, 30 to 50% of patients do not survive. Not because surgical teams are anything less than skilled and dedicated, but because an aged body under sudden, massive physiological trauma is fighting a war on every front simultaneously. The liver, the kidneys, the heart, the immune system, they are all recruited into crisis response at once. And the inflammatory cascade that a 35-year-old body resolves in days can overwhelm the regulatory systems of an older body and spiral into multi-organ dysfunction. So why does this belong in a video about surgical decisions? Because there are two things you can do right now that change the outcome of that hypothetical emergency. First, do not ignore early warning signs. Persistent, unexplained abdominal pain, changes in bowel patterns, bloating that will not resolve in someone over 60. These deserve prompt evaluation. Catching a problem at a manageable stage means treating it with methods far less dangerous than emergency surgery. Second, and this is the one most families skip, have the conversation before the emergency happens. Sit down with the people who would be making decisions at your bedside and tell them what matters to you, what quality of life means to you, under what circumstances you would or would not want heroic intervention. This is not a morbid exercise. It is an act of clarity and love that spares your family from making impossible choices in impossible moments. Now let me give you something concrete to carry into every medical appointment. Before agreeing to any significant surgical procedure, 4 questions should leave your mouth. What happens to my condition if I do not have this surgery, and over what time frame? Is there a minimally invasive or non-surgical alternative that produces comparable outcomes for someone with my specific health profile? What does recovery look like realistically for a patient my age with my current health conditions? Not the average patient, specifically me. And what are your personal outcomes for this procedure in patients over 70? That last question is the one most people never ask. Surgeons track their complication rates. The honest ones will answer you directly. And if the question is met with evasion, that response is itself a form of information. I want to end where I started, that 74-year-old school teacher. After she whispered to me about feeling invisible, I sat with her for the next half hour. We went through her options. We called her daughter. We talked to the surgical team together. She ultimately chose a different path, a less invasive intervention combined with medication management. 2 years later, she sent me a card. Inside it, she wrote, "I made my own decision. That was the medicine I needed most." A physician's recommendation is the beginning of a process, not the conclusion of one. You are not a passive figure in your own medical story. You have the right to ask hard questions, to hear honest answers, to request alternatives, and to take time before deciding. The surgeon brings expertise. You bring the knowledge of your own life and what you want from it. Both of those things matter. Both of those things belong in the room. Your age is not a complication. Your voice is not an inconvenience. Use it. Everything shared in this video represents general medical information drawn from published research and clinical experience. Every individual situation is unique. Please have a thorough, unhurried conversation with your own physician or specialist before making any treatment decision.